Blood flows from regions of higher pressure to regions of lower pressure. The greater the pressure difference, the greater the blood flow. But blood also meets some resistance as it travels through the blood vessels, so the higher the resistance, the smaller the blood flow. Blood pressure also depends on total blood volume in the cardiovascular system. We've already learned that the normal volume in an adult is about 5 liters. Anything that causes a decrease in that volume, for instance a hemorrhage, is going to decrease the amount of blood that's circulated through the arteries each minute. And with that decreased volume, of course, we'll have decreased pressure. Usually the body can compensate for small losses of blood and help to maintain blood pressure. But if the decrease in blood volume is greater than about 10% of total volume, then the blood pressure is going to drop because our homeostatic mechanisms can't overcome that. Anything that increases blood volume, such as water retention in the body or hyperhydration, also called hyponatremia, is going to increase blood volume, therefore increase blood pressure as well. So we're going to look at ways of monitoring and measuring blood pressure and the factors that the body uses to help maintain blood pressure. Contraction of the ventricles generates blood pressure as hydrostatic pressure exerted by the blood on the walls of the blood vessel is pushing against those walls, right? So blood pressure is determined by cardiac output. The more the heart is putting out, the more pressure on those vessels to contain that blood. So blood pressure is highest at the aorta and the large systemic arteries. As blood leaves the aorta and flows into the systemic circulation, the pressure is going to fall greatly as the distance from the left ventricle increases. So if we look here at this graph, you can see here we've got the aorta, then arteries, arterioles, capillaries, venules, veins, and then the vena cava. And remember, at the vena cava, the blood's going to drop back into the right atrium. So if you look at the pressure, as the heart contracts, blood is at its highest pressure when it's in the aorta, and then that pressure starts to fall as the blood flow is going farther and farther away from the heart. At the capillaries, the blood pressure is about 40 millimeters of mercury when it enters a capillary bed, and then that pressure falls dramatically to about 20 or less millimeters of mercury at the venule end of the capillaries. And then, of course, the pressure drops all the way back down. And I'm sorry, this image actually cut off, but the pressure drops all the way down to 0 at the vena cava. So the aorta has the highest pressure, and as the blood goes farther and farther away from that heart, from the ventricle, from the aorta, the pressure drops. Again, as we've already learned, the ventricles contract and relax, and as they do so, they're pushing blood out and then relaxing and filling, contracting and pushing blood out again. So the pressure in the arteries is going to rise when the ventricles contract and push that blood out, and then the pressure is going to fall when the ventricles are relaxed. So when we look at a typical blood pressure, we write it as a number over another number. So it is systolic pressure over diastolic pressure. So the systolic pressure is the pressure when the ventricles have contracted and the pressure in those arteries are at their highest. So the pressure peaks at about normal blood pressure of about 120 millimeters of mercury. The diastolic pressure is the lowest pressure, and that's the pressure in the arteries when the ventricles have relaxed. This averages about 70 to 80 millimeters of mercury in a normal, healthy adult male. So we would write this as 120 over 70 millimeters of mercury. We've already talked about the capillary pressure, and of course that's what is going to drive that fluid and some of those solutes out of the capillaries and into body tissues, as we saw in our last video. So in clinical use, the term blood pressure usually is going to refer to the pressure in the arteries that's generated by the left ventricle during systole, and the pressure remaining in the arteries during ventricular diastole or relaxation. So blood pressure is usually going to be measured in the brachial artery and usually also in the left arm. The device that we use to measure blood pressure clinically is called a sphygmomanometer. Yeah, isn't that a heck of a word? But it consists of a rubber cuff that's connected to a rubber bulb. The bulb is used to inflate the cuff, and then a meter that is on the sphygmomanometer is going to measure the pressure in the cuff. So with the arm resting usually on a table or the arm of a chair, you want the arm to be about the same level of the heart. You put the cuff of the sphygmomanometer wrapped around the bare arm. Usually if it's a very thin sleeve, it's okay to leave the sleeve on. But the cuff is then inflated using the bulb until the brachial artery is compressed to the point that it's occluded or that blood flow stops. And it's usually about 30 millimeters of mercury higher than the person's normal blood pressure, or usually about 140 to 160. So once you have the blood pressure cuff pumped up to where you've occluded the artery, the technician's going to place a stethoscope just below the cuff on the brachial artery and slowly begin to turn the little dial or turn the little button that will release some of the air to deflate the cuff. So when the cuff is deflated enough to allow the artery to reopen, a spurt of blood is going to pass through that artery, and that results in the first sound that's heard through the stethoscope. So this sound corresponds to the systolic blood pressure and the force of the blood pressure on those artery walls just after the ventricles have contracted. As the cuff continues to be deflated, the sounds are going to stop. They're going to become too faint to be heard with the stethoscope. So when you no longer hear those sounds, this is called the diastolic blood pressure, and it represents the force exerted by the blood remaining in the arteries after that during ventricular relaxation, so after the ventricles have contracted. So at pressures that are below the diastolic pressure, the sounds are going to disappear. So you have to really be careful when you're listening for these, because you'll hear the first sound as that blood flow is restored, and that gives you your diastolic pressure. At that point, you may see a small jump in the needle as well, but you have to continue to listen very carefully, and once those sounds are no longer heard, at that point, you need to check again and get that diastolic pressure. Those sounds that you hear while taking a blood pressure are called carrot cough sounds. I don't have that. Yes, I do. There it is. So there you go, carrot cough sounds. You do typically have a higher blood pressure in the morning because of the surge in some of the hormones that are associated with waking up and moving your body around, and increased circulation of thyroid hormones and others that pick up, or their secretion actually increases a little bit in the morning when your body is getting up and sort of restarting, I guess, after being asleep and resting for the night. Once we have the systolic and diastolic pressures, we can use those numbers to determine some other pressures that are important in assessing cardiovascular health. So the difference between the systolic and the diastolic pressure is called the pulse pressure. So this pressure is normally about 40 millimeters of mercury, can provide some really informative things about the condition of the cardiovascular system. So for example, if a person is suffering from atherosclerosis, remember that's the hardening, the hard plaques are building up, or if a patient has patent or open ductus arteriosus, this can increase pulse pressure. Well, what's the importance of that? Pulse pressure gives us an idea of how well the arteries are functioning based on their elasticity. So are they able to stretch and recoil as they should? So if you have an increase in pulse pressure, this can mean that there's a loss of elasticity, and of course that's indicative of several different types of heart diseases. If you have a decrease in pulse pressure, it could be that you have decreased cardiac output, and of course that itself can be caused by many different things as well. So in addition to using our blood pressure to get pulse pressure, we can also figure out mean arterial pressure, which is the average pressure in the arteries. Now there's a mathematical formula, and you may see a couple of different versions of this, but I found that this one is the easiest formula to use to calculate mean arterial pressure. So you set this up as an equation. Of course, MAP is going to be equal to your diastolic pressure plus your pulse pressure divided by 3. Okay, so the first thing you want to do is get pulse pressure. Well, how do you get your pulse pressure? Well, that's the difference in your systolic and diastolic. Okay, and then you divide that by 3 and then add that to your diastolic pressure, and that gives you your mean arterial pressure. Well, what's the importance of this? Normal mean arterial pressure ranges somewhere between 60 to 110, with 110 being a little high, 60 being pretty low. The importance of this is at mean arterial pressures of less than 60, you have decreased tissue perfusion. This is vitally important when you're looking at the perfusion or the oxygenation of some of the more important organs. Not that any of them are not important, but the brain, the liver, the heart. So low mean arterial pressures can mean that you're not having sufficient tissue perfusion. If you have a high mean arterial pressure, this can be indicative of some types of vascular damage, such as atherosclerosis, or something that's increasing those pressures. So I'm going to give you an opportunity to figure out the pulse pressure. So we have a patient with a blood pressure of 120 over 80 millimeters of mercury. So how do we get pulse pressure? Remember, pulse pressure is your systolic minus your diastolic. So your pulse pressure would be 40 millimeters of mercury. And then how do we get the mean arterial pressure? So remember, mean arterial pressure is the pulse pressure divided by 3 plus the diastolic. So first thing we've got to do is take that pulse pressure that we just got, there's our pulse pressure, and divide it by 3, okay, and that's going to give us 13, roughly, and then our systolic pressure was 80, so 80 plus approximately 13 gives us approximately 93 millimeters of mercury as our mean arterial pressure. And of course we know that does fall in the normal range, so this patient would have a normal mean arterial pressure, and of course, with it being in normal range, we would not be worried about as much about cardiovascular disease or tissue perfusion. All right, let's look at something else. What if your patient suffers from arteriosclerosis, less elasticity, and has a blood pressure of 156 over 90? And of course, you do the same thing. You figure out your pulse pressure by doing the math. For 156 minus 90 would give you 66. Then to get your MAP, 66 divided by 3 plus 90 would give us 112. All right, so let's look a little bit at pulse. So, of course, we've already looked at how you would use a blood pressure cuff, a sphygmomanometer, and a stethoscope to get an indirect measure of blood pressure. Another way that you can sort of assess a little bit of pressure is to feel a pulse. So the alternate expansion and recoil of those elastic arteries after each of the systole is going to create a traveling wave, and we call that wave a pulse. So the pulse is an easy way for us to get a quick heart rate. So the pulse is strongest in the arteries that are closest to the heart, and of course is going to become weaker and weaker in the arterioles, and then, as we saw earlier, is going to disappear almost altogether in the capillaries and then into the venules and the veins. But we can feel a pulse in any artery that lies superficial, so close to the surface of the body, that can be compressed against a bone or any other firm structure. So in this table, or in this image, we'll look at some of the common pulse points and how to find them. So the pulse rate is normally about the same as the heart rate, so somewhere between 70 to 80 beats a minute. Tachycardia is a rapid resting heart rate, or a pulse rate that's over 100 beats per minute. Bradycardia is a slow resting heart rate, or anything that is under 50 beats per minute. But we also know there are many things that can change our heart rate, therefore the pulse rate. Endurance athletes usually have exhibit bradycardia because they have a lower heart rate. But think about some of the things that can cause your heart rate to increase, therefore increase your pulse rate. If you are emotionally stressed over something, or you are doing something active, exercising, or you've been walking around, you've been carrying things that are heavy for you. So any of these things can alter this. So you do want to be sure that you are, when you're checking for a pulse rate, that you're doing so in a resting patient. So let's look at some of these more commonly used pulse pressure points. And the superficial temporal artery is located medial to the ear. The facial artery, okay, we can see it right here. So it's very near the mandible, which we know is the lower jawbone, on the line with the corners of the mouth. The common carotid artery is going to be lateral to the larynx, what we commonly call the voice box. The brachial artery, the one that we occlude when we're doing a blood pressure with the sphygmomanometer, so it's going to be on the medial side of the biceps brachii. The femoral artery, inferior to the inguinal ligament, so in the front portion of the thigh. The popliteal artery, this is going to be posterior to the knee, but of course we have an anterior view here. So for popliteal, you would look on the dorsal side of the knee. The radial artery, everybody knows where that one is, right? The radial bone. So the radial artery is there on the lateral aspect of the wrist. And the dorsalis pedis artery, sometimes just called the dorsal artery of the foot, is going to be superior to the instep of the foot. You can also use these pulse points to stop a hemorrhage, because these are going to be some of the major blood vessels in these particular areas of the body. So if you have a patient that is hemorrhaging from the lower part of the arm, if you can occlude the arteries above the hemorrhage, of course, those are going to be good places for you to be able to stop that hemorrhage and stop that blood loss.